can you please start us off by giving us a quick background into your, I guess, personal and professional experience within lower back pain, which will help sort of set us up for what we're going to talk about in a little bit more depth.
Sure. Well, first and foremost, Chris, thanks very much for having me on the show. I'm always very honored when people want to interview me or have a discussion, and it's a pleasure to share some aspects about the lumbar spine. Chris, to sum it up very plain and simply, if you have a shoulder problem, you don't want to see me. I'm very immersed in the world of lumbar spines, and obviously the periphery, like the hips and a little bit higher up in the spine. But essentially, my day-to-day practice is everything to do with the lumbar spine. Now, I've been in the game now for about 30 years. I started off as a strength and conditioning coach, and very early on in my career, I got pretty much pushed into the world of medical musculoskeletal rehab. And from there, I just found it was my passion really to understand how the body works, and especially the lumbar spine. And I took a strong viewpoint on that because I was looking for solutions to fix up my own low back problems. And about 20 years ago, I had the pleasure of meeting Professor McGill, who you've interviewed and you've mentioned many times in your shows. And 20 years later, I'm one of only 2 people in the world now who teach with Professor McGill, which is a great honor for me. And but besides that, I'm also involved in very high-level spinal multidisciplinary teams here in London. And twice a week, I meet with a very strong group of spinal orthopedic surgeons, neurosurgeons, pain management specialists, and we present very difficult cases that include stuff like cancers and tumors of the spine, to really weird and wonderful mechanical back pain cases as well. So essentially, my whole commercial life is based in the world of the lumbar spine.
Well, that helps us, gives us confidence that we're going to be getting hopefully a few knowledge bombs and whatever else the young people say these days. But we'll have that, and we're going to dig a little bit deeper into a specific type of lower back pain. We can talk about lower back pain in general, but as I know, as I'm sure you know, and as Stu knows, it does depend. So we have to sort of dig a little bit deeper, understand the pain, the mechanisms, that little bit further, so we can start to then put together some sort of plan of action with regards to overcoming that problem. So today's topic is spondylolisthesis. So just to start with, as an introduction, are you able to introduce us to that topic and how it's related to other spondy type problems in the lower back?
Sure. So, Chris, spondylolisthesis is very much a tongue twister, right? And we need to try and decipher what that really sort of large word means. Now, if we break it down into 2 parts, spondylo basically means the spine or the vertebra, and listhesis means slippage. So essentially, it's an indication that there's been a slippage of a vertebral bone in the spine. Now, it's quite well documented, and we know that lumbar discs, or any spinal disc for that matter, cannot slip. However, when a bone fractures or a particular portion of that bone fractures, the spine does have the ability to slip forward from the vertebra below it. So that is essentially what a spondylolisthesis is. And a spondylolisthesis starts with a different pathology called a spondylolysis. Now, I'm going to use a model which is probably going to illustrate this a lot better than me speaking about it. But just to orientate your viewers, Chris, so this is a lumbar spine that we're looking at from the front. So that is the sacrum, that is L5, that's L4, and that's L3. Now, if we turn it around, you'll see it from the side, and it's generally in a nice, well-aligned position. However, if we turn it to the back, and I just bring this a bit closer to my camera, you'll see that there are little bones between two larger bones. And that portion there is called the pars interarticularis. And you've got one on one side and one on the other side. And when those pars bones fracture, that is what we call a spondylolisthesis. However, if the fracture goes undiagnosed and the person continues to do certain movements that can actually produce further stresses around that particular area, the spine can actually slip forward, as I'm demonstrating there. So you'll see how it breaks and slips forward. And that is what we call a spondylolisthesis. So that's essentially the two different variations of fractures in the back of the spine. So spondylolisthesis is the fracture with no slippage, and a listhesis is where the spine slips forward.
And if we can take that on a step further, so we've got sort of the first one that starts, then if it slips, we've got the one underneath. Are there then different types of spondylolisthesis as well? And maybe what are the differences between those?
There is, Chris. In actual fact, there's six different types of spondylolisthesis, and it can get very complex. So I'll try and make it as simple as I can. Otherwise, we're going to get really sort of very medical about it. So the first type is what we call, or type 1 is congenital, or what they would term in the medical world dysplastic. So it's a birth anomaly where the bone, your actual vertebral bone, and certain portions at the back of the spine don't form properly. So they either a little bit smaller or they slightly elongated, and we call that a dysplastic spondylolisthesis. We do see them. I get to see them obviously because I'm involved in the medical world. I get to see them quite often. The second type, which is most likely the most common type that people pick up in the world of health and fitness and sport, is something called an isthmic spondylolisthesis. And the isthmic spondylolisthesis is where you have the fractures in the pars bones, and that's when the spine slips forward. A third is called degenerative spondylolisthesis. And a degenerative spondylolisthesis, and we've got it here on this model, is where you see this bone has slipped forward over the vertebra. However, there's no fractures at the back of the spine. So what happens there is there's other joints at the back of the spine called the facet joints, and the facet joints start to degenerate considerably, and they lose their ability to hold the spine in place, and therefore the bone slips forward. And that's called a degen, or a degenerative spondylolisthesis. It's very, very common in an older population group. And then you get type, I believe it's type 4, which is traumatic. So a person never had a spondylolisthesis, but they get involved in a car accident or a really traumatic accident, and they can fracture and slip the spine. In my career, I've only ever seen, I think it's 2. I've seen one definite traumatic spondylolisthesis. And if my memory serves me correct, I think it was 2. And then you get a pathologic spondylolisthesis, and that is due to cancer in the bone or some other systemic problem that actually causes the bone to break down and the spine slips. And then finally, you get something called an iatrogenic. And an iatrogenic in my world is very, very common. And we find that from people that have had previous spinal surgeries where they've had a decompression, and that's essentially where they remove certain portions of the bone, or they do something called a facetectomy where they cut away some of the facet joint, anything to that degree, but they don't stabilize the patient. And over time, the spine can then slip forward, and we call that an iatrogenic spondylolisthesis.
Excellent. So we've got now, and we could obviously, if we were continuing that direction, we could then start to investigate each one a little bit more. But what we're going to do now is we're going to sort of draw ourselves back, look at the spondylolisthesis as an entire term, if you like. And the next question is, who is most at risk? Are there certain, you've sort of introduced one of them in the last question, but are there certain populations or are there certain sports that are putting people at risk of this type of back injury?
So to answer that question, what I'm going to do is let's give a little bit of context for your viewers. So if we take the cross section of people that get the spondylolisthesis and we relate it to people who are highly active individuals, so people that generally will come on and watch your stuff and want to get involved in gym and training and sport, we're going to talk about the second type of spondylolisthesis, which is the isthmic, the one with the fractures in the bone. And usually you will find that a spondylolysis, so that's where the fracture starts, usually occurs in childhood and adolescent years. So it can start as early as about 7, and then obviously continue up until you sort of skeletally mature. And it usually is caused by repetitive movements in the spine that reach end range. So I know a lot of people like to use the credit card analogy for disc herniations, and that's not really apt. That's not a good analogy, but it's a great analogy for spondylolisthesis, because when you take the spine into full flexion and full extension repetitively, what happens is you start to provoke those pars bones, where am I? Right over there, okay? And they eventually crack. And the reason that they crack is because the pars is the thinnest portion of bone at the back of the spine, and also it doesn't have a really good blood supply. And due to that, when you fracture the pars because of repetitive bending back and forth the whole time, that's when you can pick up spondylolysis. And usually the people who pick it up in childhood or adolescent years are the people that involve themselves in sports that require their spine to go through those ranges of motion repetitively. So a few of the sports would be gymnastics, martial arts. You would then get cricket, fast bowling, weightlifting as well. So a lot of the sports that require that spine during the developmental years of the skeletal structures to go through those ranges are the sports that are usually the ones that are the so-called provokers of this.
And we've started to explore that mechanism now, which leads quite nicely into the next question, which is, how is this started? How does it kind of evolve? And are there any particular, if we sort of continue that thread of the full flexion into full extension, are there any movements, postures, loads, exercises that can increase that risk?
Well, let's start like this. How do we know what indication is there that if we're talking about kids now that pick up a spondylolysis, how do we know that they're dealing with something? What is the red flag that possibly parents need to look out for, or coaches or someone like that? Well, the interesting thing is it's a very standard presentation. And in the adolescent world or the childhood years times, you will find that kids that play certain sports will get very localized back pain. So they'll be able to tell you exactly where that pain is. It's in their lower portion of the lumbar spine. They'll put their hands around their low back, and they'll tell you that when I play the sport, my back pain increases, but on cessation of the sport, or me just sitting on the couch or chilling out and playing a few video games, I get no pain. My pain reduces completely. And that's the very first red flag that we're looking at for children and adolescents. So is where the pain increases on them continuing their sport. At that stage, it's always, if they are very active and very competitive sporting people, it's very, very incumbent upon either the parent or the doctor to then get specific scans to determine if there is a fracture in the pars bones. And if there is a fracture, they can then get into a rehabilitation plan, which first and foremost, and a lot of kids don't take well to this, is the cessation of the sport itself. So if someone is diagnosed with a pars fracture, the very first thing they need to do is stop the sport for the pars fracture to heal. because if they continue the sport, they're at a very great risk of having the spine go into a spondylolisthesis. So the gold standard of diagnosis for spondylolysis and spondylolisthesis is imaging. So radiographs like X-rays and certain angles on the X-ray. And now, even with the newer technology in MRI, we can actually scan for spondylolisthesis without the radiation that you will get in X-rays. So which has been a really good breakthrough in the medical world now for determining this in the childhood and adolescent years. So that's the first thing that I would say to you with regards to how do we diagnose it and what do we need to look out for. And as I say, if it's a child or an adolescent, you've got to be very aware that the back pain increases with activity and decreases with being sedentary. In an older population, Chris, where let's say they already have spondylolisthesis, but they don't know, because many people are walking around with asymptomatic spondylolisthesis, and the only time they ever actually get to know is when they go for an MRI because they had some type of back pain. But usually what happens in a skeletally mature population is that the pain then starts moving from the back. So you get this sort of feeling of a grumpy back. My back is always sore. It's a little bit of a toothache presentation. But then it starts migrating into radicular pain. And radicular pain means that the nerves are entrapped. They're being compressed where they exit from the spine. So I'll just show you this model here. So you'll see that the nerves exit on every level of the spine. And when you start to get compression on those exiting nerve roots, particularly on the L5 nerve roots, because that's what gets affected in isthmic spondylolisthesis, people will get pain either straight down the back of their thigh or slightly to the sides of their thigh and possibly even into their big toe. And that is an indication that then the spondylolisthesis is potentially causing neural compression. And that's when you need to go get a bit more of a further in-depth investigation to determine what is the next step to take, be it a medical route or a more conservative route via exercise.
So are those, with regards to, let's just say the nerve pain that goes down the back of the legs, are there any other sort of, what's the right word? Are there any other parts to it where, although it's the spondylolisthesis, you've then got the sort of the extension where it then can turn into that radicular pain that you talked about going down the leg? Are there any other types of those? Could there be certain muscle tightness? Could there be, with regards to the nerve going down, is there anything else like that that can come up?
Very much so. And the most common one is people that do have spondylolisthesis, and especially a more mature population, and have got this radicular pain. They'll tell you that because they're not attuned to the fact that that pain is actually neural, and they will assume that it's actually hamstring tightness. So they'll say all of a sudden their hamstrings have become really, really tight, and they're starting to feel tightness around the gluteal areas and even into their calves. So, and then what they will try and do is they'll try and stretch the hamstrings more and more. And if the L5 nerve roots are compressed, the hamstring stretches 99% of the time make them way worse, right? Because nerves don't like to be stretched, Chris. And usually that's the most common presentation. If it starts getting really pathological and bad, then people might even get to the point of where they will find difficulty in articulating something as simple as walking. So they'll either lose a little bit of strength with their ability to lift their foot. So if this is their foot, so to actually flex the ankle, or they might even get to a point of where in certain spondylolisthesis, like the degenerative type, it may become a problem with walking for any type of distances. Because when the bones don't fracture and your spine slips forward, you actually narrow the canal where all the nerve rootlets are. And as you narrow that canal, upon walking, what actually happens is you start to close down and you start to constrict that area where the nerve roots are. And people will say that they get to a point of 5 minutes and they have to sit down to relieve their symptoms. So again, an isthmic spondylolisthesis, the one with the fractures, presents very differently to a degenerative spondylolisthesis. And the symptoms are, they can be completely opposite. So that's just a brief rundown of some of the symptoms that we deal with.
Sure. And what are some of the types of, sort of, again, expanding on what you've talked about, some of it will cross over, but with regards to the pain sensations, what might someone be experiencing? So with regards to it just being the fracture, will that give a certain type of pain, like a dull pain or aching pain or like a radiating pain type of thing? What sorts of things should people be looking out for if we, I suppose, if we first talk about the pain that comes from the fracture, and then maybe a different type of pain if it progresses down into the nerve? What kind of things will people be experiencing, and what should they look out for?
So first and foremost, if you've got a spondylolisthesis, as I said, it's going to offer you, this is actually Stu's words, and it's a great term. It's going to offer you a grumpy back, right? So if you've got no neural involvement, you're just going to have this low-grade backache in your lower lumbar spine. And that generally is the major symptom of spondylolisthesis. If it progresses to a point of where there's disc height collapse, and then the nerves start to get compressed, the pain that you will feel is a very particular pain that runs down one specific area of your legs. Now, this is very interesting, and it's a great question that you've asked, because there's a big difference between what people would assume to be referred pain versus radicular pain. And radicular pain means that it's coming from the nerve, it's radiating from the nerve. Now, a referred pain is a little bit more diffuse in its presentation, and it can go down the back of the leg or the front of the leg, and it's a bit all over the place. A radicular pain that's coming from compression of the nerve roots is very specific. And the way that I always describe it to people, imagine I took a really, really sharp pencil, or even like a point of a knife, a very sharp knife, and I lightly drew down one specific portion of your leg. That, if you just feel the pain running down like a very thin, sharp pencil being drawn straight down your leg, that's radicular pain. And it can come in different sensations. It can come from a very pulsating type of pain. It can come as a deep, boring pain. It can come as a burning, or it feels like there's like hot water going down that particular area. Because then you know that the nerve is involved in that, Chris. So that's essentially the two types of pains that a spondylolisthesis patient will experience. And obviously, if it progresses really bad, it can be both. It can be both the back pain and the leg pain itself.
Now, as a final question, what I'd like to do is just talk about something that you mentioned earlier with regards to sports people, younger sports people, and to relate into and sort of add into it this part about pain. With regards to that rehabilitation, or the starting part of the process, can you talk about the importance and, in some respects, the necessity of that stage of reducing the pain and the cause of the pain, so those movement patterns? You don't necessarily have to talk about the specifics with regards to what they need to do, but just that whole principle of removing that cause and reducing that pain.
So if we take a skeletally immature patient, so child or adolescent, right, where their bones haven't completely formed, it's of the utmost importance that if I'm the clinician and we've determined that there is a spondylolysis, there's a fracture, but it hasn't slipped forward, the very first thing and the most important thing is the cessation of their sport for a certain period of time. Okay, that is key to them not having that spine slip further forward. On that, once we've taken that away and we take them through a mechanical back pain assessment, that's to determine if there's certain postures, there's certain movements, there's certain loads that either make them worse or better, then we can start putting together a very specific rehab strength-based program, because what's of utmost importance over a certain period of time for those patients is for those pars bones, where am I, right over there, for those pars bones, if they haven't slipped forward, they have the ability to heal. And it all boils down to something what we call Wolff's Law. And Wolff's Law states that bones will adapt to the stresses placed upon them. So if we are able to strategically load the bone and allow them recovery, those bones can actually heal, and they can heal a lot stronger than what they originally were. And that is the key component when dealing with your child or your adolescent patient. With an older patient that already is skeletally mature, and we know that the spine has already slipped forward and they've got a spondylolisthesis, what's really important is to determine, again, if there's any mechanical loads that will either increase the pain or decrease the pain. And if there is, then it is incumbent upon the clinician to be able to determine what this particular patient should do. So whether it's to limit the amount of sitting, to limit the amount of standing, to maybe go for short walks instead of long walks, and those type of things. However, in certain instances with spondylolisthesis, I do require one of my medics to get involved, and that's to reduce the extreme neural inflammation and neural pain. And that may come in the form of conservative interventions, such as targeted spinal injections, to reduce the inflammation around the nerve, so that I can then do the rehab protocol to allow them to get stronger, so that the reduction of the pain puts them in a better position to actually do the rehab. So I'm not against using the expertise of my medical professionals when required, and in some spondylolisthesis cases, it is required. I hope that gives you just an overview, and your viewers an overview, because it can be a very complex situation, this.
Yes, as I've sort of experienced with yourself and with Stu, it can go on for many questions, delving deeper into specific parts of different types of lower back pain as a general rule, and then further on from there. So many thanks, Chris, for, sorry, carry on.
Can I, if we've got just a few minutes, can I tell you from my perspective why I know spondylolisthesis so well? Is that I had a grade 2. That means the slip was quite significant. I had a spondylolisthesis for nearly 35 years of my life. And then in 2020, it got to a point of where I had bilateral neural pain down my leg. So I know exactly what a compressed L5 nerve root feels like. And I can tell you something, and I'm sure viewers that have experienced it will tell you it's not fun. And in June of 2020, I had to go for a surgical intervention, and I had a spinal fusion. And again, spinal fusions are for people that have symptomatic spondylolisthesis, that have failed conservative interventions, is usually the go-to surgical procedure. And I had one. It's a phenomenally huge surgical procedure. And I now have got, screws and rods and cages in my back, but my spine has been lifted, it's been pulled back, and it's been realigned into its most optimal position. And I don't have, any ridiculous pain anymore. I've got no back pain. I had quite a journey, but it's, I'm talking here from a clinician with personal experience of spondylolisthesis. And it's not as easy as when people put on their Instagram post, oh, if you've got spondylolisthesis, don't do this and do that. It's far more complex than that. And it does require a person that has the experience to understand how to test for it, how to medically test for it as well, and then to determine what the best course of action is. But many people can live with spondylolisthesis. They don't ever have to have surgery. They can do a whole host of things. And I'll go one step further, is because I see so many spondylolisthesis patients, I can tell you I've tested many, and we've confirmed very definitively that the spondylolisthesis is not their pain trigger. They've got something else happening a little higher up in their spine, and they don't ever have to worry about their spondylolisthesis. So it's a multifactorial playground.
Yes, and a journey that, as I guess you've just described for yourself, it's you know, there's never really a lost cause. There is always a sort of a way through it, a way out of it, however it really needs to be described. Well, thank you for coming on. Thank you for sharing your knowledge. Hopefully the viewers have had an education, albeit an introductory education, but hopefully, as I guess I always like to do, I like to offer more questions, or offer more questions than answers, or at least provoke questions in people's minds that can then hopefully go on to find said answers that they can follow up on. So again, many thanks for coming on.
My pleasure.
It would be great to have you on again at some point, whenever that time may be. But thanks again for sharing your knowledge, sharing your experience. And yes, it'll be great to see you again.
Thank you very much, Chris, and best to you and your viewers.
Cheers.